Hello, and welcome to today's educational webinar titled Regulatory Scrutiny in the Clinical Coding World. I'm Gloryanne Bryant. We have a disclaimer for your reference and review. I will not be going over this during this webinar. I'm Gloryanne Bryant, your presenter for today, and we have a bio for you to review as well. I do have over 40 years of experience in HIM coding, compliance, CDI, and currently I'm an independent HIM coding CDI compliance consultant. Let's review our goals and objectives for today. We are going to look at the OIG work plan and its purpose. We will be looking at the 2022 work plan coding targets. Those include malnutrition diagnosis, telehealth, targeted MSDRGs, HCCs, COVID-19 diagnosis, and some others. In addition, we'll be providing you information on some OIG audit reports that really are specific to coding and the vulnerabilities around coding, for example, under the hierarchical condition category diagnosis coding. And then we'll, throughout this program, talk about documentation and strategies for coding compliance for us to improve our overall coding skills, processes, and accuracy. Okay, so let's begin with a little background. In the largest sense, regulatory compliance in healthcare is about providing high-quality patient care. Healthcare professionals routinely compile and access electronic health records, and therefore maintaining the patient privacy, the data accuracy, and results of those are collected, and they become a vital component to our healthcare industry across all settings. Remember that abuse, fraud, and waste is a very important target by our federal government, by our state and local governments, as well as private healthcare plans, insurance payers. I've provided some definitions on abuse, fraud, and waste here on this slide. August of 2021, the Department of Health and Human Services had imposed penalties, monetary penalties, in the total of $135 million in 100 cases, more than 100 cases. And this is a year ago. So you know that now this year we probably have another 135 million potentially. That's a lot of money to think about in healthcare specifically, that we have issues, we have problems, we have overpayments. The OIG, CMS, ZPICs, RACs, MACs, CERT, RADV, there are so many regulatory inquiries, audits, investigations going on an annual basis by these different regulatory bodies. We, in health information management or in CDI, need to be aware of these regulatory-based activities, what they're looking for, as they provide us with clues into their techniques for data mining, clues into what they're looking for, such as fraud, waste, and abuse. The Office of the Inspector General, OIG. This is a screenshot from their website, and I wanted to cover a little basics on the OIG just to make sure everyone is very clear. This particular branch of the Office of the Inspector General is under the Health and Human Services. We have the OIG and many other branches of the federal government, but this is specific to Health and Human Services. And under Health and Human Services, the mission of the OIG is to help organizations provide objective oversight to promote the economy, efficiency, effectiveness, and integrity of HHS programs. Now, under Health and Human Services programs, we all are very familiar with CMS, the Centers for Medicare and Medicaid Services, but there are a variety of other programs that fall under that are also looked at. I would recommend that you take a look at this OIG website, get familiar with it, and routinely visit it. We'll talk about why in a few moments. The OIG work plan is an important document that outlines all the different projects that the OIG will be working on within a given year. However, the OIG work plan is a fluid work plan. They can update it at any time during that year. So yes, we look at the annual work plan when it's published, but we should continue to look at it throughout the year. The work plan identifies audits that may be being done, if they're going to be inspecting or evaluating, if they're going to be investigating different areas, and it lists the projects that I mentioned that go beyond CMS, and it can include the CDC, NIH Institute, a National Institute of Health, could be the Administration of Children and Family Services, it could be the Administration on Community Living. So there's a variety of areas, and Indian healthcare is also one of the areas they look at. And in that work, they look at the programs that are being instituted on a federal basis or programs that use federal funds. So at the state level, quite often, the states are receiving federal funds. Or at the local level, they may be using federal funds. So certainly the federal government under HHS wants to look at those and make sure they're used appropriately. Now, some of the work plan items do reflect work that the OIG is statutorily required to do. Others could be a whistleblower or a hotline. It could be some other area that's in the industry known to be problematic, but there are specific things that are statutorily required. The first work plan item that I want to bring to your attention around coding is inpatient coding of mechanical ventilation. This is your procedural coding area. However, of course, the whole medical record would need to be looked at to be able to validate this. Now, the work plan outlines that this will be an area of focus this year, 2022, and they'll be looking at those beneficiaries or patients who have received more than 96 hours of mechanical ventilation. Now, why would that be important? Well, we want to make sure that they actually did receive more than 96 hours. So the timing and the documentation of the time and length on mechanical ventilation is going to be very important. One trigger that you can see right off if you run data, which they have done, is look at the length of stay. If the length of stay is less than these 96 hours, yet we're coding these 96 hours or more, there is a flag right there, and that should be looked at and reviewed and audited. Now, by putting this on the work plan, you may think, well, it's kind of a new target. It actually is not. The OIG did do an audit report back in 2013 and talked about the overpayments of the mechanical ventilation coding of 96 hours or more. Now, back in 2013, when this was released, DRG 207, DRG 870 were a primary target, and they identified through that audit back then that 7.7 million in overpayments over a 3-year period had occurred. Now, we're talking today about 2022 work plan. So look at the time that they have been kind of studying, looking at data, and really keeping their eye on the inpatient coding of mechanical ventilation. Here we were back in 2013 with this audit report saying this may be a problem, and now we are in 2022 with a work plan focus on this. Right out of the work plan, I've included some language for you, and they describe, of course, the mechanical ventilation use, when that would occur, and that they are have identified improper payments made to hospitals who inappropriately billed the beneficiaries who did not receive at least these 96 hours. So there's a screenshot there in the bottom in the box, table box that you see, announced in November of 2021 that this was in the work plan, and its expected issue date for their results of what they conducted will be in 2023. So there's a lengthy period this year, 2022, when they're focusing on this. I mentioned that there was a 2023 audit report. This is still available. It's public, and I put the link there at the bottom of the slide for you, and a screenshot from the cover. This was in September of 2013. And one of the questions that this all comes to mind is, since 2013, have you been looking at your data and your coding and your documentation, of course, around this procedure code of 96 hours or more of mechanical ventilation? When you audit, are you getting into the ventilation flow sheets from respiratory therapy and looking at that documentation? Now, we use a lot of electronic health records, of course, and so we would probably see those ventilation flow sheets pretty clearly. In a paper world, we also had sheets and pages of these flow sheets for the time the patient was on them. One thing I've seen, because I have audited in the last year for a client, a couple areas in here, is that BiPAP sometimes can get confused with this continuous mechanical ventilation, and the patients can sometimes go on BiPAP, off of BiPAP, and then back on it. Likewise, they can go on continuous mechanical ventilation. We could take them off. They seem to be improving, but they could have a relapse, and then they're put back on the continuous mechanical ventilation. So, are you auditing in this coding risk area? Are you looking at the PCS code? Are you looking at the ventilation flow sheets as part of your audit work and validating that? Please put this on your list of things to look at. The next area is, again, inpatient coding, and it is for the diagnosis of malnutrition. The work plan has identified severe malnutrition as a target area. It results in a MCC under the MSDRG payment methodology. The work plan states that hospitals are allowed to bill or code and bill for treatment of malnutrition on the basis of the severity of the condition, the mild, moderate, or severe. It's severe malnutrition, however, that is classified as a major complication or comorbidity, or as we know, an MCC. By adding the MCC to your coding, to your case, your encounter, or the claim, it results in an increased payment if that is the only MCC on that particular encounter. So for MSDRGs, the Medicare Part A fee-for-service, this is the target area that they're focusing on. Not to say that this wouldn't be a target area for Medicare Advantage for HCCs, because it has been identified there as well. I went back in time because we've been, yes, talking about this for a number of years, malnutrition. And it dates back over 7 years where we have had audit reports produced talking about malnutrition. Way back in early 2014, an audit was conducted in prior years to that, and it identified that kwashiorkor, and you may remember this, kwashiorkor was identified to have been coded and not supported by the medical record documentation. This resulted in higher payment. There was a series of audits targeting a variety of hospital systems, focusing in those in 2014 on kwashiorkor. You can see from the bullets that are listed, starting at the bottom, Palmetto was that first one, and then Mother of Francis, Overlook Medical Center, Baptist Medical Center, Methodist Medical Center, and Rex Medical Center. And then in 2017, so there was a break, and then in 2017, they put together a report that there was discrepancies in the coding of this and the classification of kwashiorkor as well. Well, we thought that kind of put that to the end of it, but it didn't. In 2018, the University of Wisconsin through an audit report that the OIG did, declared that they had inpatient claims with severe malnutrition that were incorrectly coded, and to Medicare. And then in 2020, another large report that summarized severe malnutrition as being a target for inpatient hospitals, and that over $1 billion with a B dollars was overpaid by Medicare. So with this work plan focused risk area, this is going to be interesting to see what comes of this from the work they're doing this year, as they will be looking at a variety of hospitals across the US. What you want to do is focus this severe malnutrition is the current one, but I would even run a report to see if the kwashiorkor code, ICD-10-CM code, is in any of your claims, any of your hospital inpatient encounters, or even outpatient encounters for that matter, and look at the documentation, the clinical indicators, bring in your CDI, work on it together, and see what you find. Do you have supporting documentation? Now, there has been, of course, problems with published information that has been varying, and there has been some published information by Aspen that has identified the clinical criteria for malnutrition, and sometimes that isn't a match completely linking up with how we classify it in the coding system, so it can be problematic. You might want to, when you're doing this audit, bring in a dietitian also. So you'd have a CDI, a dietitian, and an inpatient coding professional reviewing some encounters. I'd start off with maybe 50 of these for the last year. Now, the focus the OIG has said is an MCC. So it's a single MCC that is making that DRG pay more. Those would be your primary target. But you'd also want to look at some others where it's not the single MCC, just to see if we've got a tender pattern in this area. So put this on your list as well as an area of focus. Now, a potential overpayment target has been also listed on the OIG as inpatient coding of COVID diagnosis, COVID-19. Under the COVID or Coronavirus Aid Act, Section 3710, because we are in a pandemic and they declared some changes to our coverage under this particular pandemic situation, they provided an increase in the weighting factor of the DRG for those encounters, inpatient encounters who had the COVID-19 diagnosis, up to a 20% increase. So they were giving us more money. It was costing a lot more money also to take care of, as we know, the COVID-19 patients in the hospital inpatient setting. Very, very ill, a lot of resources. So this is a target area and it's in the work plan. Yes, they are giving more money for this particular diagnosis in the inpatient setting, and we should be pulling some of these and auditing these encounters as well. So I would go back to your 2020 timeframe when we first started seeing these particular cases, March of 2020, going forward, and look at some samplings from 2020 and 21 and 2022 as well. We are still in the pandemic status. They do review that declaration every 90 days and make the determination of whether they will continue with all of the specific changes in the healthcare coverage, etc., and continue with it being declared a pandemic. We are still in that status. The next area I wanted to mention is an outpatient area on telehealth. And telehealth is the remote or virtual delivery of healthcare services. And I'm sure most of you are very familiar with this and know that we have in healthcare harnessed technology to help with video chats, remote patient monitoring, phone calls, video phone calls, a variety of ways of communicating and connecting with the provider and the patient. During the pandemic, of course, telehealth made a huge leap and a huge increase. I think it's like 5 to 6-fold what we were doing prior year of 2019. So by adding this to the work plan, they are looking at the auditing of this. They're going to audit it. They're also going to be doing an evaluation inspection process of the telehealth policies that are in place. They're going to be looking to see if we are following the policies and requirements. There are documentation requirements for telehealth services. So this would be an area to, again, pull some encounters for specific to the COVID pandemic, which created the challenges and changes around the access and delivery of healthcare. The OIG will be determining if new policies and technologies provide potential improvements in the care and access to healthcare through this telehealth, or do we have any fraud, abuse, or misuse of the telehealth services? There have been some investigations focusing on that. The OIG will include the impact on public health emergency flexibility, and they'll compile their information and their reviews and make recommendations to inform the public, us of course, but policymakers, because healthcare policy around telehealth is very important. And they will see if they need to recommend any changes in policy around telehealth. You can go to the OIG website. They do have a featured topic around telehealth, as you see from that little graphic I've included. Also on the OIG work plan is another outpatient area. This particular one talks about place of service. Now, you may not watch this that carefully or key this in very carefully. It's in our Part B, primarily physician services. For our physician services do have a difference in payment depending on the place of service. And so non-facility rates are higher than facility rates. A 2018-2019 audits that were conducted determined that physician providers were paid at the non-facility rate, which is higher than they should have been. So again, we want to watch. It's a little detailed specific area is the place of service. So outpatient physician encounters, this will be an area to focus on. If you're a healthcare system and you have physician group practices as part of your healthcare system, yeah, you should pull some of those outpatient physician encounters and check the place of service on those. The OIG place of service will look at potential overpayments in 2020, 2021. So let's do that as well and look at our 2020, 2021 services. Now, the OIG has a work plan I mentioned. They also produce what's called the semi-annual report to Congress. This is a public document as well. I always access this too. There's not usually a lot of specifics around coding, but it does give some targeted areas, and it tells Congress what they are going to be looking at. What are their significant findings in the past, in the recent past, and what are their recommendations, the recommendations of the OIG to Congress. And sometimes action is taken based upon those, so it's important to know that. It's a handy report to look at, in addition to the work plan report that's good to look at. But the favorite of mine of all the OIG things to look at is their audit reports. These come out all the time and anytime during a year. As you can see from this screenshot from the OIG website, under Health and Human Services, those blue bulleted items are hyperlinks to the area. And on the area of the Office of Audits, these are the areas that they will utilize their staff or outside staff that they'll hire to perform audits. And there are a variety of areas that they look at. I chose the fourth on the list, the Centers for Medicare and Medicaid Services in particular, to look at what they plan to audit in this area. So one of the other things I want to mention is the timing of all that. These audit reports take sometimes years and years to conduct and then produce the report. So we're thinking, oh, they're not very timely. Well, they're timely enough in that we should then go back and look at some of our retrospective activities going back a few years. So although we've heard already in this webinar about 2020 and 2021 and even 2022 to do some activities, there are some that go back even further in years that you may want to look at as well. Okay, so let's start with this first one from that audit report. So this is a target. It's not in the work plan, but it has an audit report, and this is a red flag saying they found problems here under bariatric surgery from under the Medicare program. So fee for service and bariatric surgery in the inpatient claims area. They have uncovered through their audit report, which was performed from January 2018 through July of 2019, the audit period, that there was a large amount of money for bariatric surgery under Medicare that was produced. Now, there are eligibility requirements that we should be very familiar with, and their eligibility is very specific. This audit found that some of this is not being met. The title of this particular audit report was Hospitals Do Not Always Meet Differing Medicare Contractor Specifications for Bariatric Surgery. I have conducted a bariatric surgery audit last summer, and one of the elements we looked at was the MAC requirements and then compared that to our encounter. So that might be something for you to think about, is to pull some of your bariatric surgeries, identify your Medicare Administrative Contractor, MAC, and look at their website requirements for bariatric surgery coverage, and then compare that and use that as an element for your audit. Another area that they have produced an audit report, and this was just in February of this year, is around Medicare Advantage compliance. This was an audit around diagnosis coding, the health plan. Now remember that Medicare Advantage is Part C of Medicare. It combines coverage of A and B into Part C, called the Medicare Advantage program. And it is risk adjustment based. High risk diagnosis have a payment and can have a grouping into a payment or an HCC, a hierarchical condition category. It is the health plans that contract with Medicare. And then, of course, hospitals and physicians provide services for those beneficiaries who are enrolled in that health plan having the Medicare Advantage coverage. The OIG focused on specific selected diagnosis codes submitted to CMS by the health plan. The health plan gets those codes from the hospitals and physicians. And they felt that there were some problems in this area. So let's take a closer look here. The OIG used data mining techniques. They did discussions with medical professionals, and they identified higher risk diagnoses were being miscoded. Some people use the term overcoding, miscoded, and it seemed to consolidate into some specific groups. So they found 7, what they call high risk groups, that have diagnosis coding incorrect, and the first one was an acute stroke. An acute stroke does have a hierarchical condition category payment methodology. They said that one physician claimed during the service year, but did not have that diagnosis on a corresponding inpatient claim. Now, an acute stroke is something that you are admitted to the hospital for. So their data was finding that, oh, we have a physician claim, a pro fee claim of an acute stroke, but we don't have any hospital claim of an acute stroke. So we have a mismatch there. They found that a diagnosis code history of stroke, which does not map to an HCC payment, typically should have been used. So heads up here on your hierarchical condition category for HCC for stroke, you want to look at your physician claims and see what diagnosis code was used. Now, certainly a physician bedside, hospital bedside encounter for an acute stroke could have that diagnosis code. But after the acute stay, or they're missing an acute stay, that would be a red flag. Another one is acute heart attack, acute myocardial infarction, as we know. And in here, one physician did not have that, a patient did not have that diagnosis on the corresponding inpatient claim. Same situation, using the acute diagnosis, getting an HCC when it should have been more of a history of, and in the acute stroke, it should have been a lesser disease manifestation of the cardiac condition. Could have been unstable angina, could have been ischemic heart disease. And then there are those that had combinations of both acute stroke and heart attack in the data. Also, embolism, or what we call vascular disease, which has an HCC, was also identified as a problematic. They did not have any anticoagulation medication dispensed, and the anticoagulation medication is typically used to treat embolism. So the data could tell them this. The diagnosis of history of embolism should have been used. That history of does not have an HCC payment to it, where embolism does. Vascular claudication was another targeted diagnosis they found in this one. And this, again, should have medication dispensed for this condition, but in instances, the vascular claudication was not supported in the medical records. Major depressive disorder, and this has an HCC payment with it for bipolar and paranoid disorders as well. And they did not see any medication for antidepressant dispensed on their behalf in the data. The major depressive diagnosis was not supported from the medical record review. And then they found a couple interesting ones, and this, dates back some time because I've audited many, many years, and keystroke, we're using the computer. Yeah, we all make little keystroke errors. Well, this one was kind of interesting in that it dated back to ICD-9. If you were coding a 250.00 diabetes code, but your fingers didn't hit the right key and you put 205.00 rather than 250.00, you would have ended up with an HCC for metastatic cancer, which pays more than the HCC for the diabetes without complication. And they identified 811 scenarios in which that happened. So that was kind of interesting at the same health plan. So I would drill back to what institution it was, what providers, so we could see, well, where was the keying, the data entry errors occurring. It's always good to look at those little switcheroos in very common conditions, the 250, and then you're typing in 205. Another audit report that they looked at was Medicare Advantage, again, health plan, and they took those same 7 focused areas that I just mentioned. So this is getting to be a little targeted area. And they did find that there was HCCs that were not validated, and they did result in overpayments. So they looked at the medical records, they looked at diseases with manifestations, and they looked at the HCC payments on these, and they found overpayments. Another area that they looked at was MS-DRG. So this is Medicare Part A. We were talking about Medicare Advantage, which was Medicare Part C. Under the inpatient stays, they did identify inappropriate billing practices, billing practice being an upcoding practice. And there is a nice report by the OIG on this trend toward more expensive inpatient stays. So these are higher weighted DRGs is what they're talking about. And these particular stays are vulnerable for upcoding or higher coding. And so this would be a great audit area, the high-weighted MS-DRGs to scope in your audit. And I would conduct both internal and external audits in this area. It's always good to have a separate set of eyes externally looking at some of your practices and your coding and documentation. In this particular area with DRG upcoding, they found 49.7% of the errors were in cases or DRGs with a single MCC. So high, they call that a high level, severity level. At least one secondary diagnosis was considered to be in major. And then they have medium severity is when we have one secondary diagnosis is a minor or just a CC. Low severity is no secondary diagnosis that results in a complication comorbidity. And then they have some MCCs that are not divided by severity. Nearly half of $109 billion that was spent on inpatient stays in 2019 was for stays with the highest severity, and that's that 49.57%, almost 50% of the inpatient hospital claims in 2019 were all with this at least one secondary diagnosis with an MCC. Interesting, isn't it? That the data showed that. Now you can run a similar data report yourself on your own MCCs and try to program through maybe decision support to identify, of course, the principal, but your very first secondary diagnosis to see if it is an MCC or a CC or no CC. These were the DRGs that they felt have problems. Sepsis, that doesn't surprise any of you, I'm sure. So DRG 870, 871, 872. Notice, of course, these have mechanical ventilation in them as well. So there could be a double review, a focus there on making sure that we have the appropriate MCC, but also mechanical ventilation codes. Pneumonia, that's also not a surprise. That's been going on for years and years. DRG 192, 193, and 194. That they looked at. So there's where you can run a data report and look at some of those, look at some cases in each of these to see if you have the appropriate documentation and coding. And then some other MSDRGs, as we mentioned, are just having single MCC or CC. And then the other area that's kind of interesting is when we have an MSDRG where the principal diagnosis does not match the principal procedure. So you have that mismatch that comes about. And what happens is the MSDRG ends up being a relatively high weighted DRG. So those are these 6 DRGs that I've listed here: 9, 81, 82, 983, 987, 988, 989. Now, some of this happens because within that 3-day window, the patient may have had an outpatient surgical procedure and rolling that into the inpatient claim. We need to make sure we're following that 3-day window rule carefully. And I put some information here for you. You can download some information from CMS about the 3-day window rule, which is important to review. A lot of billing software does a sweep of that 3-day time frame and just pull anything and everything into the claim. So it's good to take a look at that. Now, it applies when we wholly own or wholly operate that outpatient entity. So that's important too, because if it's an outpatient entity that we don't own or operate, then this does not apply. And then we have a report on telehealth. Remember, that's in your work plan, but this is the audit report. So as I mentioned, from the work plan, we want to focus on this, but I would review this audit report, which gives you a lot more specificity around the claims they actually reviewed and looked at. Now, 24 of the claims that they looked at were unallowed because the beneficiaries received services at non-rural originating sites. 7 claims were billed with ineligible institutional providers. You have to have the right provider. 3 claims were for services where the beneficiary had an unauthorized originating site. 2 of the claims had unallowed means of communication. So the technology communication was not allowed. 1 claim had non-covered services. 1 claim had a provider physician located outside the United States, which is not allowed. So you can see that there's a variety of areas that we can then proactively look at. We would take each of these focused areas that they found problems, and we would check to see if we have any problems in this area as well. Now, the OIG has stated that we should regularly review our compliance elements. This review should be conducted at least annually and should include an assessment at each of the basic elements. Do you remember what those basic elements are? Think about compliance program elements. Well, they do include auditing and monitoring, education, external and internal is good to have in this area, again, to mention that. Don't just rely internally on your own set of eyes that are part of your organization. We can get a little biased sometimes in that. I try not to, but it can happen. So an external review is always good. I wanted to mention CERT because maybe you're not looking at the CERT report. It does provide some great information. This is the Comprehensive Error Rate Testing Report for 2021. Shows again issues surrounding documentation. This is a great report to look at and discuss with your CDI leadership. 64% has insufficient documentation. Insufficient documentation, and this is both a combination of inpatient and outpatient claiming. I wanted to briefly mention that skilled nursing facility compliance has some requirements that for those of you that may work in that area, I've just listed them there. I'm not going to read through them, but this would be a good one. If you have a skilled nursing facility as part of your organization or you work in that setting, review this because these are the compliance elements that are very important for you to have in place. There is another annual report that comes out that is really important, and this is from the Department of Justice, the DOJ, Department of Justice. They produce a healthcare fraud and abuse control report, and for every $1 that is spent on combating fraud and abuse, $4 is returned. So they feel they're having a good return on investment with this program. You can download this report as well, it is public. It did tell us that in fiscal year 2021, they won or negotiated more than $5 billion in healthcare fraud judgments and settlements. So that money would come back into the Medicare healthcare program and the trust fund. One common question I sometimes get from CDI and coding professionals is, well, how do I report any potential waste, fraud, abuse? Well, of course, you should have internal reporting structure in your organization to your compliance department. You may have a hotline. Those are areas where you should go to, and you probably have a policy that talks about reporting it internally. You do have the ability under the federal government to report directly to the OIG. They have a hotline and an online form that you can submit your complaint and they will investigate. They also have a call-in number that you can use, which I've listed here as well. This is an important area. There's a lot of fraud, waste, and abuse. If they're able to recoup $5 billion in this particular area, imagine the areas that don't get looked at and we don't recoup. The monies are wasted out there. When we talk about these coding errors that could occur, how do we correct them? What is our process? What is your process for doing that? Do you have your steps outlined? First of all, I would ask, do you have a policy around making coding correction? You should. When we make a coding correction, we should have something connected to the billing business office, and it should be resubmitted to the payer. So you're going to want to coordinate and discuss. If you haven't got a good process, then reach out to their director or their manager and say, let's put together a good process, a good policy. When we make a coding correction on our side, in the coding department area, how does the billing department area get that correction to the claim and then to the payer? We also should be creating a log so we have a tracking of these changes. Some organizations like to put a tracking log internally in your intranet in your organization that is used by HIM, coding, CDI, or the business office. If it's an overpayment, goodness gracious, absolutely. It doesn't matter when it happened. You need to refund, rebill, resubmit to the payer. Give the money back. And there are very specific legal requirements, and I emphasize legal, on the rebilling of overpayments that we need to follow. Now, certainly if it's an underpayment, Medicare does have specific Medicare, and other payers do too, timeframes for resubmitting the underpayments. But I want to focus on the overpayments and the requirements. So we've made a coding correction. Maybe it changed the DRG to a lower weighted DRG. We want to course correct the coding on that encounter, but we want the billing to be corrected and it go to the payer. Medicare requires 60 days after the date of the overpayment was identified that we need to have submitted this overpayment back. So you have a time frame, the clock is ticking. Do you have billing component that is watching the timeliness of these overpayment identification? Because if you're holding on to those overpayments and the government goes through an audit and you've gone over the 60-day period, they could find a violation at your organization. So check on refunding also co-payments. This is specific to your outpatient area, I find quite often, because under the APCs, we have different co-payments for different APCs, different CPTs. And if we're changing around CPT codes in our Medicare, we could be changing our co-payments. So that would be another area to look at. And again, you want to make sure you're refunding co-payments, because this could be a risk area, to the beneficiaries. But in overall, how is your rebilling being validated? Do you ever go back and check to make sure that the rebilling actually took place? Horror stories I've heard from some of our colleagues and peers out there in HIM, CDI coding is that they thought it was rebuild. They thought that it was rebuild, that the business office had taken care of it, but it never occurred. So here's where we need a heads up and make sure that we're taking some action around this particular correction of our rebilling and rebilling. But how do we prevent these mistakes from happening in the first place? Yes, we all make mistakes, we're human, but we should be proactive. Awareness is first. Be aware of the problems. Read the work plan, read the audit reports. Discuss them with your CDI, with your coding staff. Develop a list of issues and risks. And that includes the medical necessity piece of it too. There are some issues around, of course, the bariatric surgery, but also neuro. Stimulator has had medical necessity issues in the last year. You might need clinical validation, so you want to both pull in a provider or a clinician to review a particular encounter or encounters. Be aware of coding irregularities. You have audits probably. Do you discuss the errors, the mistakes that are made? Have regular staff meetings. Talk about coding guidelines that are hard to understand or you have questions about. Discuss your audit findings. Address general coding documentation questions. And provide ongoing education. Run data report analysis, similar to what the OIG described in some of these reports that I was mentioning or in the work plan that they talked about. Audits should be both internal and external. That's truly a best practice. Review your coding and CDI policies and procedures. Do you have them in place and are they in writing? And again, it's always important to have an outside separate set of eyes. Look at your policies, procedures, look at your auditing, look at what you're doing for education, look at your rebilling practices and query practices, just to get a separate set of eyes given input. Some key action to take around is, of course, your HHS rules and regulations, Medicare Part A, B, C. D is the pharmacy side of Medicare Advantage drug plan. Remember that being proactive is way better than being reactive. You've got an audit being conducted by the government that now you have to react. Let's be proactive. Be aware of these audit reports and what they're saying, they're focusing on. I gave you a few today that you can make a list with, and then you can conduct some focused audits in the area. These are be focused. You also should be doing random audits as well, but focused audits can give you the OIG targets then, inpatient, outpatient, physician, and other settings. Summarize your findings in these audits, or who conducts the audit should be summarizing those and sharing them with leadership, and have a corrective action plan That includes rebilling. Identify and trend documentation issues from an audit. Gather together CDI and coding and talk about them. Develop and conduct education based upon audit findings, CDI, coding, and providers. And again, that rebilling timeliness is so important. Healthcare compliance is the formal name given to be proactive to prevent fraud, waste, and abuse in healthcare. So make your compliance part of your HIM coding DNA, part of your department, part of your company and your day-to-day operations. Coding compliance plan or program should have these key elements, which the OIG has said is a compliance program should have. Who has oversight for coding compliance? Do you have a code of conduct for coding compliance? And we have those available from our professional associations. We can mirror them. Do we have written policies and procedures? The OIG says we should. And are those reviewed and updated appropriately? How do we communicate changes and information to our staff? Do we have education and training in place? It should be ongoing throughout the year, not just once a year when the updates and code changes come. We should have education throughout the year. And our auditing and monitoring in place, and then how we respond and enforce. These are all key elements to overall compliance, but can be adopted and embraced in our coding compliance. Make sure to document all your external and internal education. I actually participated in an organization's corporate integrity agreement activities where they were being re-looked at every year for 5 years. And in that, the OIG actually came back and asked, where's your education material? When did you present it? Who did you present it to? Do you have a sign-in sheet? Did you do a quiz? I mean, it was all detailed information. And I obviously had all that available. So think about creating a file, a folder, electronic folder where you locate all this information. And make it a commitment to have essential coding resources. Some of these resources do not have a cost to them, such as the official coding guidelines, but Coding Clinic does have a subscription. CPT Assistant does have a subscription. Having updated code books, whether they're electronic or paper, that should all be part of compliance in healthcare to diminish your risk. Conduct periodic in-services. These really complement your corporate and your individual department compliance program. And I mentioned keeping records of those. Patterns and trends around documentation, deficiencies and problems, awareness education for physician providers on improving documentation. This can be conducted by your CDI staff or your HIM leadership. And then clarify conflicting, ambiguous information with the physician. Follow the practice brief for querying from 2019. When clarifying and adding information, make sure this information is in the medical record, the permanent record. So if we ever release that record, we have the updated information. I had this question come up to me. Well, the official guidelines are guidelines. They're not real rules. That's not true. On the first page of the guidelines, it says the guidelines are a set of rules. Right there, they are rules that need to be followed. And why? Because, as you see in the last sentence on here, or second to last, they are part of HIPAA. It is a HIPAA requirement. There is a law behind following the guidelines, following the rules. So yes, those official guidelines need to be followed. It is a law. And for ethics, if you want to review the AHIMA Standards of Ethical Coding, this is a great document to help. I've been many times in organization, we've seen these being utilized as our HIM coding, ethical code of ethics that we've used to just adopting this, and that's acceptable as well. So in summary, I want to say that the OIG work plan is really a window into many targeted areas for fraud, waste, and abuse. There is the semi-annual report to Congress, which you can utilize as well, and it can be valuable. The OIG work plans, as I mentioned, are really a great way to see the detailed findings and their corrective action. I've used those many times myself to do a focused audit to know where to draw my attention to. The CERT report is a good thing to look at every year as well, and take action and include both fee-for-service, FFS fee-for-service, and risk adjustment, like Medicare Advantage, or the HHS HCCs under the Affordable Care Act. And then auditing and education, make sure it covers all the areas that you are getting reimbursed for, and make sure you have the correction in place, the corrective action plan for rebilling, and it needs to be timely. If we do this, we can have prevention, and that will go a long way in diminishing our coding risks that we have across healthcare. So the question is now, did you make a list of your action items that you're going to do in the next 30 days, the next 60 days, based upon the information you've received today? I hope you have, and that you're being very proactive in this and will be moving forward. If you have any questions, please contact MRA, and the link is listed there at connect@mrahis.com. If you have questions about the presentation content or other coding related issues, you can contact MRA. Thank you very much for attending today's educational program. It was a pleasure to present this information to you, and I hope it has helped you see where we in the coding area have risks, but can be proactive in preventing fraud, waste, and abuse. I have a list of resources that you can access as well. And I thank you again for attending.